This video describes the surgical protocol for the replacement of the missing cuspid through the first molar of the maxillary right quadrant. The patient is a 59-year-old female with a shortened dental arch and an existing partial dentue. She would like to have her dental arch restored to match the opposing teeth with an implant-supported restoration replacing the existing partial denture. Her medical history is insignificant and she has no allergies. The existing thickness of bone is insufficient and the bone level below the maxillary sinus is inadequate to place an implant to support the first molar. The patient was advised she will need both a horizontal ridge augmentation plus a sinus elevation prior to implant placement. The ridge augmentation will be completed first, and the implant will be placed at the time of the sinus elevation using the Crestal sinus elevation protocol. A cast was made of the patient's maxillary arch with the removable partial denture in place. A vacuform shell was made with holes indicating proposed locations of implant positions from the existing prosthetic teeth on the partial denture. The vacuform shell is placed over the cast made from an impression of the patient with partial denture removed. 30 seconds, holes were drilled through the vacuform shell into the center of the ridge on the cast. The angles of the 30 seconds drill placement are checked on the cast. Fabrication of the diagnostic guide is completed with two 3 mm guideposts and two 3 mm guide sleeves from Deplaque. The diagnostic guide is fabricated using Primatech light cured gel and Primatech splint and is placed in the patient. A cone beam X-ray is taken of the patient with the diagnostic guide. The two planned implant sites with 3 mm guide sleeves indicates a significant correction may be needed. Higher magnification of site number 6 with diagnostic guide sleeve indicating the bone is too thin and very close to the adjacent implant in site number 7. Higher magnification of site number 3 with diagnostic guide sleeve indicating a sinus elevation will be required and the angle of the guide sleeve will need to be corrected palatal 8 degrees. To provide space for the graft material, a IG titanium membrane was placed. The graft is composed of two osteogen strips and infuse BMP2. 15 minutes prior to placing the graft beneath the titanium mesh, 100 micrograms of BMP2 is reconstituted with 1 milliliter of sterile water or saline, which is added to the osteogen strips. This is a clinical view of the sites for the proposed osteotomies, number 3 and number 6, distal to number 7, which require ridge augmentation. Two vertical releasing incisions were made, with reflection of a full-thickness buccal flap. Cortical bone is perforated to expose cancellous bone and provide a pathway for mesenchymal stem cell migration into the graft. The IG membrane is stabilized with two screws at the crest and contoured with a gap on the buccal surface for the placement of the grafting material. Two osteogen strips were placed in a petri dish. On the left is the strip to be hydrated with 50 micrograms of BMP2. On the right is a strip already hydrated with 50 microgram BMP2 and 0.5 milliliters sterile water for 15 minutes before placement beneath the titanium mesh. The osteogen strips are carefully placed beneath the titanium mesh while avoiding placement of the mesh too close to the adjacent implant. Ossix, a resorbable collagen membrane, is placed to cover the graft material closer to the adjacent implant in the number 7 position. Closure of the site is made with a combination of mattress and interrupted nylon sutures. The partial denture is relieved to ensure there is no contact with the widened alveolar ridge. The anatomical view indicates the placement of the titanium mesh. The post-op cone beam image indicating the titanium mesh contour and the thickness of the graft at the anterior site with the proposed implant placement. Post-op CT, the buccal lingual slice, is marked by the location of the mesial fixation screw. A slice through the location of the distal fixation screw indicates the need for the sinus elevation at the location of the distal implant site. These are the steps to cut the osteogen plug into small pieces after the BMP2 has been added in sterile water. First, cut the osteogen plug in quarters lengthwise. Next is the application of 50 microgram or more of BMP2 in 0.40 milliliters sterile water for 15 minutes prior to adding the graft. Cut each quarter piece to smaller pieces for the elevation of the sinus membrane for placement with the adjustable depth stop plugger. Here is a visual of the steps for the Crestal sinus elevation procedure to create the space. The drills push the autogenous bone up to lift the membrane, which is followed by pushing the collagen graft material up with the adjustable plugger to gain additional height for placement of the implant. These are the Crestal sinus elevation drills. They are designed to be used pre-cooled with a flapless protocol. A serial drilling procedure without irrigation reduces risk of dilution of the biologic BMP2 or GEM21S, which can be used to increase the speed of mineralization of the Crestal sinus elevation. 3 months post-ridge augmentation. After the ridge augmentation is completed and the mesh is removed, the sinus is elevated and a periapical X-ray taken after placement of the first osteogen plug plus BMP2. The Crestal sinus elevation is completed and the implants are placed. Second stage surgery is completed 4 months after placement. The implants were torque tested and healing abutments were placed. Buccal view. The final restoration was placed 10 months after the case was started. This is the palatal view of the completed restoration. To view the protocol for the Crestal sinus elevation procedure in more detail, or the use of the technique for lifting the sinus membrane with the sinus models made from number 15 sawbone blocks, and the surgical protocol, go to YouTube/Guiderite protocol/Crestal sinus elevation, or go to the website at deplaque.com and click on resources.